Good afternoon and welcome to the SRTRs webinar this summer on the reporting for OPOs. My name is John Snyder. I'm the Director of Transplant Epidemiology at the Scientific Registry of Transplant Recipients here at the Hennepin Healthcare Research Institute in Minneapolis, Minnesota. Today's webinar will focus on metrics, risk adjustment, and an exciting new development here at the SRTR, the provision of CUSUM charts for the Organ Procurement Organizations to monitor donor yield. So we're excited to share that information and teach you a bit about those charts as we go. We will have a Q&A session at the end. On your WebEx, there should be a Q&A portion of the interface on your screen. At any time during the webinar, feel free to enter questions you may have in that Q&A session. The team here will be monitoring that as we go through the webinar. And we will try to address as many of those questions as we can at the end. If we, by chance, aren't able to get to your question, we will respond to you individually following the webinar. But just so you're aware, there is a Q&A portion where you can enter questions directly. We will not have live audio at the end of the during that Q&A session. So the only way to ask us questions is to enter that information into the Q&A portion of the interface. I always like to begin with just reiterating the mission of the Scientific Registry of Transplant Recipients. We are a federal contract operated by the Health Resources and Services Administration, their Division of Transplantation within the Department of Health and Human Services. And our mission is to provide advanced statistical and epidemiological analyses related to solid organ allocation and transplantation in support of the Department of Health and Human Services and its agents in their oversight of the national organ transplantation system. We fulfill that mission in a number of ways, many of which we will touch on in the OPO community during this webinar. What I will touch on is the SRTR's contractual requirements. There are things spelled out in HRSA's mandate to the SRTR for things they would like us to be providing both to the public and to the OPO community to help further the transplant system in this country. I will touch on current OPO metrics. Of course, not all of the metrics we provide, but I think the major metrics that are provided by the SRTR currently. I'll touch on some future developments in that area as well. A little bit about risk adjustment, and then finally we'll spend a bit of time on the new CUSUM charts for monitoring OPO yield that will be coming available very soon. And again, a Q&A period at the end of the session. I always like to get a good understanding and just to help us continually improve our webinars for the future. I like to understand who's listening in. So we're going to start today with just two polling questions, and I will open this poll. This one is simply to describe who we have listening in. And so you should see a poll opening on your screen now, and we have about a 30-second window where you can choose an option. Our assumption is that most of the people on the webinar today are personnel from Organ Procurement Organizations, but perhaps there are others as well. So would love to just learn more about who we have here. So we've got a few seconds left if you haven't entered yet. Just waiting for the results to pop up. Clearly, most of the folks that have entered in as I watch along here are organ procurement organ personnel, which is great. That is, of course, our target audience for this webinar. So happy to have you all with us. So yes, indeed, looks like the vast majority of people here are OPL personnel as well. I will move along to our second polling question. We know that many of you are perhaps listening with a group of people from your organization. So our second polling question is simply asking how many we have. This is good for us to just understand if we're able to reach our target here. So just indicate if you're alone listening today or you have a few people with you. We like to just have a record of how many we're able to reach through the webinar. So appreciate you filling that in as we go. This helps us understand how many we're able to reach. And while we're waiting for those results to come up here, I will mention that all of our webinars are posted publicly as soon as we're able following the webinars on our SRTR website. I'll have a shot later about where you can find our webinars on our website, but they are all posted as YouTube video links. So if you ever want to review the material that you've heard today or any of our prior webinars, they are all there publicly available on our SRTR site. So it looks like we've got a fair number with us. Many of you are in groups within your organization, so again, happy to have you with us today. So let's jump in. What I want to touch on first is why the SRTR does some of the things that we do. In our contract, Task 3.9.1, to be specific, asks us to develop program-specific reports, or PSRs, on the performance of transplant programs and organ procurement organizations. Some of the key clauses within that task are that we are to disseminate for free over the internet timely and accurate program-specific information on the performance of transplant programs, and the OPO information included shall include organ donation, recovery, and discards. Obviously, in the reports, we have a lot of that basic information about how many donors and how many organs are being transplanted, how many are being discarded. That's all there in terms of just key numbers that would be there for your OPO. But indeed, we have a fair number of metrics as well, in other words, calculations based on those numbers. Finally, transplant programs and OPOs with better or worse outcomes shall be identified. And so I'm going to touch on a few ways that we do that within the reports as well. And just to orient you to our website, if you aren't familiar, you can find your report for your organ procurement organization if you go to our homepage at srtr.org, and then look under the Reports and Tools menu at the top, and then the fourth item down currently is the Organ Procurement Organization Reports. That is where you can navigate to find your specific report for your organization. They are currently available as PDF documents, so they're printable documents for each of your reports. But we are, teaser for the future, we are working on more advanced ways to display that data for you that we hope will be more engaging in the future. So that's where you can find that. I will touch on a secondary contractual obligation, and that is to provide quality improvement tools for organizations within the transplant system to monitor their outcomes. The task here at 3.9.4 is that the SRTR should continue to develop and provide tools for performance improvement by transplant programs and OPOs. Specifically, this task calls out the OPO Yield Calculator, which I've highlighted in bold here, and I'll talk a bit about that as we go. And then in the last paragraph of that task, this is where it indicates that we should continue to provide CUSUM charts. These are quality control monitoring charts for 1-year patient and graft survival for the major transplant programs outcomes. And that we should make those available on the SRTR Secure website. It goes on to say we would develop CUSUM charts for pancreas programs when we have those available. And then this last clause that I've bolded in that is really what led us to want to provide CUSUM charts for the OPOs. So we have the CUSUM charts for transplant programs to monitor their outcomes for post-transplant outcomes. And offer acceptance. They're currently available for transplant programs to monitor. But here this clause here, in consultation with HRSA, the contractor shall develop CUSUM charts for additional metrics to monitor outcomes and systems performance. And we had heard from a number of folks in the OPO community that it would be nice for OPOs to monitor in real time, or as near real time as possible, their donor yield metrics. Those are the metrics that are currently used by the Membership and Professional Standards Committee of the OPTN And so to be able to have a more real-time monitoring of that and to see trends over time in how well your donors' organs are being transplanted. So we worked with HRSA on finding the effort to do this within the contract, and HRSA was very supportive of that. So those are going to become available next month. So we're excited to share those with you. So let's step back for a moment and just hit some highlights about how we conceptualize and capture the donation process in the context of metrics. So what metrics capture pieces of what is a very complex process, as those of you working in organ procurement organizations understand well. If you've seen our presentations on this concept before, you'll be familiar with our sort of concentric circle approach to the concept. And this is simply to help orient us to how we think of developing metrics. And you can think of this as a funnel, or the concentric circle idea is what we've gravitated toward. But essentially, you understand the process where we have a certain number of deaths within your donation service area. Some of those may be in-hospital deaths. Some of those then are ventilated deaths. And of those ventilated deaths, a smaller proportion of those would be actually potential donors. And I have this in quotation marks because I think this is a current area of hot debate, is what do we mean by potential donors? But indeed, if you are able to access that potential, you would have authorized donors within that pool of potential donors. And some of those authorized donors, perhaps not all, would go on to become actual donors. That is to say that they would have at least one organ recovered for the purpose of transplant. And then, of course, of those, there might not be any organs actually transplanted after they're procured. However, that inner circle, the transplanted organs, is, of course, the goal that we're all hoping to achieve within the system. And so one concept is any one of these circles, you could compare the actual size of the circle. These circles, of course, aren't to scale in this drawing. But you would be able to quantify the size of that circle and compare it relative to any other circle you chose. In so doing, you would construct a metric. So this is how we think about constructing metrics. Now, if you're a savvy viewer, you would note that I have circles A, B, C, and D, and then I jump to circle G. So we're missing an E and an F here in the middle. And I simply do that to say that there are subsets of the donor potential that we as a community quantify into imminent and eligible deaths. Those of you working in OPOs are very familiar with these definitions, so I'm not going to sort of lay out the definitions of each of those, but I simply show these to say that, A, this is a subset of actual donor potential. We know that we're able to achieve donors that don't meet either of those definitions. That's why those inner circles are offset within that broader donor potential area. The reason that we have these definitions, the eligible death definition is a definition that I think the OPO community, through the OPO committee of the OPTN, has agreed sort of meet qualifications that would typically be donors or potential donors. And so it does provide a somewhat standardized definition that has been improved over time. So it's recently the definition has changed, and it's quite a detailed definition, but it gives us some sense of a standardized definition. Those of you familiar with it, of course, understand that this definition of eligible death, these must be brain-dead donors, so this does not include any potential for donation after circulatory death. So all of our DCD donors are not included in that eligible death definition. And so I think it is a subset of donor potential that we can access, and we do, and I will show that. But I think it's a limiting concept, right? It's a limiting concept in terms of understanding true donor potential. That broader circle D, I think, is what we'd really like to be after. So I'll just, for now, I will eliminate that, and let's just focus on these bigger circles here and think about some of the metrics we currently have today. So if we're thinking about a metric of donor conversion, our numerator of that metric is going to be how many donors do we have? Of course, that would be this blue circle here. So this includes donors from whom some organs were transplanted, as well as all other donors for whom at least one organ was procured for the purpose of transplant. And we might compare that to this donor potential circle. So if we're able to quantify the size of each of these two circles for each of your OPOs, this would serve as the basis for a numerator and a denominator of a metric from which we could construct a percent conversion, which might start us along the path of having a metric to better understand performance. Of course, this is only step one of the process. We would then also ideally have a model to say, how do we then compare those percentages across the 58 OPOs? We all know that the OPOs serve different populations and have different characteristics of their potential donors, and so we need to have a model that can help us understand and better predict what we would expect at your OPO given the types of population you're serving and donors that or potential donors in your service area. So this is sort of one step, is just how do we think about constructing these metrics. Now again, we don't have this potential donor definition collected in any standardized way currently. I think there's some exciting work going on in that area. So this is a metric that the SRTR currently does not report. This is something that we're actively working on in partnership with AOPO. So this hopefully will be in the future able to present some more interesting information in this regard. So what do we have? I come back to this eligible death box here. One of the metrics in the SRTR reporting currently is limited down to this eligible death population. So if we take the orange rectangle here as our denominator, we understand right away that this is not a full capture of donor potential, but it is a capture of potential donors that meet this eligible death definition that has been agreed upon by the OPO community. And then if we are able to count how many donors emerge from that eligible death pool, here that's this strangely shaped almost quarter circle that pulls out. So again, this doesn't capture full donor potential, nor does it capture full breadth of donors. And so this is the construct in our reports now for eligible death conversion rates. It is a metric we can calculate. It has limitations, which I will touch on. But just to orient you to where this is in our reports, I'm going to give one example just from the service area that we happen to reside in here, the LifeSource donation service area in the upper Midwest. LifeSource, as you know, serves Minnesota, North Dakota, South Dakota, some counties in western Wisconsin as well. And just to orient you, this is the report from the current LifeSource Organ Procurement Organization report on the SRTR website. And just to orient you to this table B1 within the report, this is where we present this eligible death conversion metric. And so here we see that LifeSource during this period of time from January 1st, 2018 to December 31st, 2018, so it's a one-year window, there were 172 eligible deaths reported within the LifeSource donor service area. And of those, 123 of those became donors. Okay, so simply constructing this metric, we're going to divide 123 by 172, and that results in the line there, observed donation rate per 100 eligible deaths. So this is the eligible death donation rate, 71.5. And then what we do is we have a model that predicts an expected donation rate based on the types of eligible deaths occurring within the service area relative to what's happening in other service areas as well. Here we have a limited number of factors that are collected on the eligible deaths. So this model adjusts for age, gender, race, and cause of death. So given that limited adjustment, it's not an ideal adjustment, but this is what we're able to do given current data collection on the eligible deaths. And so the eligible death predicted donation rate here at 76.0, and we then compare that. We divide 71.5 by 76, and that results in the 0.94 standardized donation rate ratio presented toward the bottom of this table. And then the p-value simply is a construct of how is this significantly different from 1.0. 1.0 would be that the eligible death conversion ratio is right at the national expectation. So slightly lower than that, but not significantly so here within this service area. So again, a standardized donation rate ratio below 1 would indicate slightly or lower than expected conversion of eligible deaths. Above 1, if say it was 1.1, that would say that there's a 10% higher conversion of eligible deaths relative to expectation. So that is where you can find the eligible death conversion rate within the current reporting structure. We also then provide a bubble plot, if you will, of where this OPO sits relative to its peers. So on this plot, figure B4, which is presented alongside the metrics I just showed you, the shaded dot, of course, is the OPO of interest in the report, and the other dots are the other 58 OPOs. We stratify this from left to right by the number of eligible deaths reported within your service area. What this does is it allows you to simply compare your OPO to perhaps other OPOs of similar size. And so you can say the LifeSource OPO here sort of falls in the middle sort of that cluster there, both in terms of size, and is slightly below the 1.0 line for national expectation on eligible death conversions. The reports also then break down the eligible death conversion based on the organ type. So we present similar metrics here of observed and expected donation rates per eligible deaths within each of the organs. And so you can find this in the report. The plot to the right simply shows on a figure similar data to what's shown on the left with the observed donation rate ratio for each of the organ types compared to the national average would be at the 1.0 line. So you can see how you're doing within each of the specific organ types. Now, I touched on this. There's some controversy around the use of eligible death conversion, and there's been some recent publications. I thought I would just highlight two of them. This was Cannon and colleagues presented recently in the American Journal of Transplantation. And they were, if you focus on the right map of the two here, the deaths per 1,000 population, in this paper they analyzed the geographic clustering, if you will, of the death rates per total population, and noted that there is geographic clustering, so OPOs or donation service areas that are approximately close to one another often have similar deaths per 1,000 population. That's the first observation. And then if you look at the map on the left, they analyzed the same concept by looking at eligible deaths per 1,000 deaths. So this is saying of those deaths that were in those service areas, what proportion of them were reported as eligible deaths. And they noted here in this map that there was a non-significant geographic clustering. In other words, there was little evidence to suggest that OPOs that were near each other had similar reporting of eligible death rates within their total deaths in their service area. From this, they were skeptical of using the eligible deaths as a denominator. And so I think that probably all of us would agree that we can do better than having to limit this metric to eligible deaths. And so I know there's lots of work going on in this area. We are involved in that as well, and we're hoping that in the future we'll have another webinar where we are able to roll out some new concepts looking at this donor conversion metric. Another paper I'd highlight is from Dr. Goldberg and colleagues recently in the American Journal of Transplantation as well. Here he has a figure that has the SRTR reported OPO observed donation rate per 100 eligible deaths along the x-axis of this figure, and then compared that to another conversion metric developed using the CDC multiple mortality files that are publicly available from the Centers for Disease Control. That metric's denominator, as labeled there on the y-axis, was donors per 1,000 inpatient deaths under the age of 75 from causes of death consistent with donation. And Dr. Goldberg's observation here is there's not much, very little, if any, correlation between those two metrics, so those metrics would be telling us something different. Of course, if they told us the same thing, then it wouldn't matter which one is quote-unquote correct. And so, here's an argument to say that perhaps we should investigate this further and come up with a better denominator by which to look at the performance of the organ procurement organizations. So that paper would suggest, made the recommendation to use this broader denominator, and I don't have it clearly delineated on this figure, but this would be sort of the concept. If we have the numerator again being total donors, that's an easy one to count and to tabulate. But then this broader circle, we would widen that other circle out from circle D, which was potential donors, almost all the way out to in-hospital deaths. And I put an asterisk on that because the definition advocated for in some of the work has been to limit the in-hospital deaths to those under the age of 75 with causes consistent with donation. So the CDC multiple cause of death file would allow us to construct such a metric. So that is under investigation as well. Having said that, you'll note from the figure here that this does not enable us to limit to ventilated deaths. And of course, the ventilatory status of the decedent at the time of that hospitalization is crucial to becoming a solid organ donor. So I think ideally we would like to find a way to get at the ventilated deaths. There are other data sources. The National Inpatient Sample is one example that may allow us to get closer to that ventilated death denominator. But there's some challenges with that file as well in terms of being available for the entire country and the timeliness of that file, et cetera. So while I don't want to get into lots of those issues today, I just wanted to make this community aware that these discussions are ongoing, and hopefully we can arrive at a better denominator in the future. I'm going to switch gears here and talk about donor yield. This is one of the other main metrics used within the SRTRs reports. And again, this is the metric that the MPSC, the Membership and Professional Standards Committee of the OPTN, is using to monitor system performance for the OPOs. And here the numerator is how many donors have organs transplanted. So that's that innermost circle here. And the denominator is total donors. And so both of these concepts are well quantified within the OPTN data. So this metric, I think, it's been in the reports for a number of years, and I think most of the OPO community is very familiar with these metrics. I'll just highlight an example where these appear in the reports on the SRTR site. This is in Table C3, which is the observed and expected organ yield. We do report this over a 2-year period. Remember that the eligible death conversion rate was a 1-year period. So this report in the example I'm showing here, which is an older example that I pulled, this was a 2-year period from year 2015 and 2016. I highlight in blue just the heart column, and this is where we show how many organs were actually transplanted. That's the observed number of hearts transplanted in this example at 108. The expected from our modeling here is that there would have been 100, so there is slightly more than expected hearts being transplanted from the donors from this organ procurement organization. And then down the line here, we standardize that to organs per 100 donors. And then we have an observed per 100 minus expected per 100. So that would say that there are 3 more hearts being transplanted per 100 donors compared to what we would expect. So a slightly higher than 1 observed to expected, or O to E ratio. So those are the metrics right at the bottom of this table that the MPSC is looking at when they do their evaluation. Similar to the eligible death conversion metrics, we have bubble plots for each of the organs showing where your OPO stands relative to your peers for each of those yield metrics as well. The SRTR website does have a guide to the key OPO metrics, so if you want to find a bit more information about some of the metrics I've shown you here, under the About the Data tab on the SRTR website, there is a guide to key OPO metrics. So we hope that's helpful. I just wanted to point that out to you, so if you want more information, you can find it there. A bit about risk adjustment. How do we do this risk adjustment to account for differences in the population across the different OPOs? I'll just highlight a few places that you can find more information on this. Under our reports and tools on our website, you will find risk adjustment models for OPOs. Okay, this is where you're going to go to find how the models work to derive an expected value for your organ yield metric. Okay, when you click on that link, you will be taken to a tool that looks something like this. This is the SRTR's OPO Yield Model Documentation application. You would simply, we make two versions of this available that updates every 6 months, so you can see the current models or the models that were in use 6 months prior. So this is currently highlighting the July 2019 release. Then you would choose which organ you're looking at. We have different models for each of the different organs. And then there's a number of tabs below, and they are labeled yield predictors, model coefficients, model element plots, and additional information. And just encourage you to look through this. On this tab that's showing here, we have the yield predictors, and the table below simply lists out everything we include. It doesn't show you what the adjustment factor is on this table. This is just simply saying, here's all the things that we're taking into account when we try to assess what we would expect your yield to be from any given donor. If you want more detail, the actual coefficients are shown on the Model Coefficients tab, and then the Model Elements Plots tabs allows you to draw a figure, essentially, showing you how the risk adjustment works. And so you can see more information there for any one of these risk factors that's adjusted for in the model, how that adjustment actually occurs. And the Additional Information tab simply has more information. I wish I could show you more on that today, but it's sort of beyond the scope of today's webinar to get into that level of detail. But I will highlight that we did provide a webinar approximately 2 years ago on this exact topic. So if you go into our News and Media menu on the SRTR website, you will find a link to our webinars. And I note in the title of this slide that on August the 23rd of 2017, we provided a webinar on how the risk adjustment models work for the OPO yield models. So I would just encourage you, if you want more information to better understand that, please know that that is there. And you will have to scroll down in the webinar list a bit to find that webinar, but that's the one that was August 23rd of 2017. So what tools do we make available for the OPOs? The tools are all available on the newly developed SRTR Secure Site. Here's an image of the home page. Hopefully you all have access to this site, or someone within your organization has access to this site. These are all provided behind a secure, password-protected login web page for your OPO. A number of things are available there that I will highlight. The OPO Yield Calculator is a standalone web application that you can download from the website. This allows you to sort of in real time input information about your donors, and then the tool will give you the expected values from the current models on the SRTR website. I will mention that we are beta testing a command line access to this tool, so that you could program from your electronic system right into this tool to have it return the values for you. So if that's something you are interested in, we should be rolling that out soon. That's in sort of a testing phase currently, but that is something we've heard from the community would be helpful, so that is in the works. There's another site within the Secure Site. There's a file you can download that offers you a chance to look at what transplant programs in the nation are high acceptors of certain types of organ offers. I'm showing you one example here. We call this our OPO Offer Acceptance Report. This is publicly available, not publicly available, it's available to each of the OPOs through that secure login. And what this does is it gives you a tab for each of the organs, and then you can look at which transplant programs have high, above average, all the way down to below average acceptance of these types of offers. And you can look at it based on different classifications of donor offers. This tab that I have open on this example is for liver offers for PHS increased infectious risk donors. And you can see the transplant program codes there. So Mayo Clinic St. Mary's Hospital has an offer acceptance ratio in that first line of 2.69. This suggests that they're accepting these offers at a rate 2.5 times higher than expected. The next one down is Mayo Clinic Arizona, which also has received a large number of offers, 379. They accepted 33. The expected was 11.5, so again, about 2.5 times the acceptance. And so we hope that this is helpful for having conversations with your transplant programs, but just to better understand who the data suggests are high acceptors of these types of offers. You can look at DCD offers here, hepatitis C positive offers over 50 in the match run. That is to say, you know, they've already been declined 50 times or they're over 500 miles. So we hope this type of report is helpful. Those classifications change for the different organs you're looking at. So this was something the OPOs had asked about a few years ago, and so this has been available for a while on the site. So hopefully that's a tool that is useful to your organization as well. So this is the exciting news, in my opinion. Starting next week, August 1st, we will be releasing CUSUM charts for OPOs to monitor yield. If you're familiar with what we've been providing to transplant programs, these will look familiar to you. If not, no problem. That's why we're having this webinar today, is to really focus in on these charts. These charts exist for you to track trends in your donor yield for specific organs over time. And so I'm going to show you a few examples just to help orient you to these charts and just give you a high-level overview of what they look like, what they mean. These charts are going to provide you with data over a 4-year period. Okay, and some have asked, well, why 4 years? I said, well, the MPSC monitors yield over a 2-year period, and CMS monitors yield for each OPO over a 3-year period. So we wanted to make sure we gave you at least more information than what both of those observation windows are for those different regulatory bodies. And so we thought a 4-year window might be a reasonable choice here. So you can always zoom in on these plots. And at a high level, this trend line over time is telling you, if it's flat, say maybe hovering around the 0 line, that would suggest that you're transplanting as many organs as we would expect from those donors. So staying right sort of flat around 0 would suggest that you're right on target for what we would expect to be yielding from your donors. A line trending down, and this may seem counterintuitive, and I'll get to why we do it this way. If it's trending down, that suggests that your yield is better than we expect. So going down is the direction we want to see in these charts. Sort of flat or down is a good thing. If it's going up, that suggests that you're transplanting organs at a rate that's slower than what we would expect or lower than what we would expect. The reason we do it sort of opposite of what you might think is logical is that these types of charts, if they're going up, we want that to be the quote-unquote bad direction, okay? So going down is a good direction, going up is a bad direction. And I'll tell you a bit more about that as we go through. So again, as we start to look at this, think of this as over a 4-year period of time. We're tracking how well your organs are being accepted and transplanted from your donors. A bit more about this y-axis on this chart. This chart, if you look above the chart, is labeled the expected minus observed CUSUM. What this is doing is it's tracking cumulatively over time how many more or less organs are you transplanting compared to what we would expect. Okay, so the y-axis actually has an interpretation here. Again, if it's at 0, that's saying that you're transplanting exactly the same number of organs over time that we would expect you to be transplanting. So if you subtract the observed from the expected, or the other way around, expected from observed, you would get 0, okay, if you're right on target. So in this example, at the rightmost point on this chart, this OPO is at about -20, right? So -20 is going to mean that they have transplanted 20 more livers than the models would expect. Remember, it's expected minus observed. So a negative number means you have a greater number of observed than we would expect. So -20 is a good thing. We've got 20 more livers transplanted over that 4-year period of time cumulatively than what the models would expect. Likewise, opposite, if it was a positive 20, that would say 20 less organs than we would expect over time. So again, if the line is trending down over time, this means that over time that OPO is transplanting more organs, or organs at a higher rate than the models would expect. Again, the models are based on national experience for similar donors through those risk adjustment models that I pointed out on our website. So here's a different example. This is also a liver yield CUSUM. This one is trending up over time. This means that over time the OPO is transplanting organs at a rate lower than expected. And so you can see here over that 4-year window, we had a positive 200 approximately on this one, which would suggest that there were 200 fewer livers transplanted than what we would expect based on what's happening in the rest of the country for similar donors. One of the challenges with these types of charts is as an OPO personnel looking at these charts, how do you know when is it going up just randomly, or when is it going up that's like an indication of true trend over time? And so with each of these charts, we have two charts. They come in a pair. We give you the expected minus observed CUSUM, which shows the trend over time. That's not going to tell you if it's quote-unquote statistically significant trend. It's just going to give you a sense of, are we going up or down, or are we having up and down moments across the chart? But that's going to be accompanied with what we call a one-sided CUSUM. And this is the one that provides you with a test of whether the pattern is possibly random noise, or is this something that we have enough evidence that there's a real trend happening here, that there enough evidence suggests that your yield is significantly lower than what we would expect, okay? So what that looks like is this. So here's the one-sided CUSUM on the right that accompanies that left plot of the expected minus observed CUSUM. And indeed, we have a red trigger line at the top, and if the chart hits that line at any point during the 4-year period, it will reset to 0 and then continue monitoring again. I'll tell you a bit more about that in a second. But this is where it's going to tell you that the plot has accumulated enough evidence to suggest that this isn't just random noise, that there's a real trend happening here. You can see in this example that this chart hit the signal line twice over that 4-year period. So there was enough evidence at about the July of 2016 mark in this chart that the yield was significantly low. The chart resets, and then the same pattern continued thereon after, and it hit the line again in January of 2018 and so on. So if I was an OPO personnel looking at this, this is telling me that there's enough evidence here that this is significantly below expectation over that period of time. So again, we have this trigger line at the top. If it hits the red line, that's the evidence that we have enough statistical evidence to suggest that this isn't just random fluctuation in your yield over time. This one, again, hit that line twice over that 4-year period. And again, we reset the line. If it hits the signal, the chart automatically resets to 0. This simply is done because the concept in quality monitoring is if you were monitoring this real time, you may have pulled the team together and assessed your processes and what your situation is, and if you've made any changes, the chart would start monitoring again, assuming that there was sort of a change in process that may have occurred. So the chart would be able to tell you, are we now sort of better or worse? In this case, the trend sort of stayed the same after that point, and indeed the chart marched up and hit the signal line again. So here's another example again of lung yield this time, and this is a chart that sort of meanders down for a bit and then it starts to turn around and meanders up for a bit. So if I was an OPO person watching our yield patterns over time, I might, without even knowing if these trends are significant, I might wonder, why in the first part and back in July of 15 through looks like January of 17, we were having higher than expected yield, and then it turned around and started to march upward for a period of time at a lower than expected yield over about a 2-year period, and then it's starting to come back down again. So I think it's an interesting pattern. I just highlighted it just for, if I was your quality personnel at your OPO, there might be some questions to ask there is what was really happening over those periods of time. Now, is this a significant pattern or might it be random noise? This is where we would refer to the one-sided chart, which looks like this in this case. And you see here it sort of hovers down around the 0 line. That's just saying that there was no evidence at all early on in that chart that anything was lower than expected here in terms of yield. And then you can see when it turned around, it did start to march up, and then it's coming back down. It didn't hit the signal line, so this would say that maybe we didn't accumulate enough evidence that this is a real trend happening. That doesn't mean that it's not real. It just means that we don't have enough evidence yet to suggest that this is likely not a false positive. But again, a personnel at your organization may look at that and maybe know what was happening. Just a quick anecdote, when we rolled these out for offer acceptance practices at transplant programs, I presented a similar type of chart where it looked like something changed over time at one of the transplant programs. And I had one of the personnel at the program tell me, like, oh, yeah, I know exactly what happened there. We changed some personnel, and some people were more or less aggressive than other people in terms of accepting offers. And so the pattern made complete sense. And so I think that as you begin to digest these charts and understand them, maybe you will know over time, what may or may not be changing within either your OPO personnel or the transplant programs you're mainly serving. I think it hopefully will provide some interesting data to the community. So where can you find these? Once you log into our secure site, again, these are coming August 1st, so next Thursday, you should be able to find these on your OPO page. If you go to your Reports tab after you log in, you will find a box there under the Reports for CUSUM charts, and then it will allow you to choose which organ you'd like to see and for which period of time. As they roll out every month, these will be updated on the first of every month. So every month you'll get a new chart available to you to monitor this in real time as possible. This is where you will find them. Just point out there's also an FAQ there that will be available to you to learn more about the CUSUM charts. And as always, you can reach out to the SRTR, and we're happy to answer any questions that you might have about these charts as we roll them out. With that, I would thank you for your attention. I'm hoping that we left some time here for Q&A. So I am going to introduce a few of my colleagues here. Dr. Andrew Way is our primary biostatistician that's worked on the CUSUM chart development for the Organ Procurement Organizations, and also is responsible for the organ yield models that we use to publish the expected values on the SRTR website. So Dr. Way is here with me in the room as well. I also have Amy Ketterer with me here. If you've ever reached out to the SRTR through our help desk, you've likely encountered Amy. Amy fields the majority of the questions coming through our help desk, and so she's with me here as well and has been monitoring the Q&A chat box on the WebEx application for us as we go. So I will turn it to Amy, and she can field any questions we've received thus far. And Andy and I will do our best to answer them.
Thank you, John, and welcome, everybody. Thank you very much for joining us this afternoon for our OPO webinar. The first question that we have is there an available database that contains inpatient deaths and ventilator status at time of death or ever ventilated during terminal admission? How current is the CDC mortality data?
Great question. This is something that the SRTR has been looking into just recently. And obviously the publications I pointed to have looked at these data sources as well. One publication I didn't mention is the Dr. Clausen's publication on deceased donor potential that came out of UNOS OPTN. That also has very good information on trying to assess donor potential using what I refer to as administrative databases. And so the question here is how current, I'll take that one first, and how current are these data sources? Let me start by orienting you to what we have for the eligible death conversion rate currently in the reports. The July 2019 reports that were just released a few weeks ago have eligible death conversion rates for calendar year 2018 in them. So they're running at about 6-month lag to real data. So the July report contains calendar year 2018. The report we release next January will shift forward 6 months, so we will have mid-2018 to mid-2019. So again, running at about a 6-month lag in that report. The CDC multiple cause of death file that has been suggested, that's the one that would allow us to use in-hospital deaths under the age of 75 with causes of death consistent with donation. Again, that data source does not have ventilator status on it. The current file available from that data source is calendar year 2017. The calendar year 2018 data will be available, I believe, in December. They usually release the updated years in December of the current year. So in other words, this coming December 2019, the CDC will make available calendar year 2018 data. Now, the implication of that is we currently have eligible death conversion for calendar year 2018 in the report. If we move to the CDC file as a potential denominator, that would back up that. The current report would only have calendar year 2017 in it, so it would back up that by 1 year. The last part of that question was the data source for ventilator status within those hospitalizations. The best source of information for that is what's called the state inpatient database or state inpatient data sets that are mostly compiled by state hospital associations. These are actual inpatient discharge data that have of course, the procedure codes and diagnostic codes available on those hospitalizations. If the patient was ventilated during the hospitalization, there would be a code for mechanical ventilation on those hospitalizations. To my understanding, and I'll caveat this with I could be wrong, but to my understanding, that does not allow us to know what patients were ventilated at the pronouncement of death. Okay, this is just were they ever mechanically ventilated during the hospitalization? Was there evidence of, was there on the bill within the inpatient hospitalization, was there a bill for mechanical ventilation during that hospitalization? Those databases at the state level are rolled up into what's called a national inpatient sample. That national inpatient sample is a sampling of hospitalizations from those state inpatient data sets. So it's not a complete reckoning of the U.S., it's a sample. And indeed, it contains, I believe, currently 47 states plus the Washington, D.C. area is included in that file. There are 4 states that do not report into that file. So that poses a challenge. We may not be able to make a metric using that database for the entire U.S. And the last thing I'll say about that file, if we use it, it's currently available only in 2016. So we would be backing up that conversion metric by 2 years. So again, current report for eligible death conversion has 2018 data. If we use CDC, it would be 2017 data. If we use the national inpatient sample, it would be 2016 data. Long answer, apologize for that, but great question.
Great. The next question is in reference to the CUSUMs. What is the lag time with this data?
Great question. We will release them monthly. There's a note on the CUSUM chart that the most recent month's data for donors might be incomplete. We present the most recent month that we have available. So in other words, the ones that are released in August, and Dr. Wade can correct me if I'm wrong, the ones released in August will have donors through the end of June. So there's just about a 1 month lag in those reports, with the caveat that the June donors may be incomplete. As we look at this, we find that donor information really is captured quickly within the OPTN data system. And so there isn't much of a lag at all. We're providing you as near real-time data as possible, so about a 1 month lag, correct, Dr. Way? Yeah, he's shaking yes. Yeah, okay, perfect.
Okay. Has there been consideration of redefining donor to only be those who have an organ that is transplanted, i.e. eliminating zero organ transplants? If yes, what has been the discussion around that?
Great question. To be honest, I haven't been a part of any discussions about changing that definition. I think that definition has been fairly well accepted within the OPTN SRTR reporting constructs, where we define a donor as having at least one organ procured for the purpose of transplant. I know there's been debate about what does procured mean even, and I know at one of the AOPO meetings a few years back, there was a whole session on how do we define what it means to have an organ procured. But I think in general that's been the accepted definition, and I haven't been a part of any conversations wanting to change that definition.
Right. Can you comment on why OPOs with more than 200 eligible deaths have standardized donation rate ratios above 1.1, figure B4, compared to many smaller OPOs that have higher SDR ratios?
Well, this is all just based on what we would expect based on the types of donors that we have, given the risk adjustment we're able to make on the eligible death conversion rate, right? So we're only able to adjust those for age, gender, race, and cause of death. And so regardless of the size of the OPO, this calculation is based on how many, given those combinations of age, gender, race, and cause of death, how many donors are we expecting from those eligible deaths relative to what other OPOs are able to achieve. And so it is possible that a small OPO can have a high or low donation rate relative to that, same as a large OPO. So simply being a large OPO does not mean, because it's relative to expected, right? So a large OPO, of course, we expect more donors to be there, but because that doesn't mean their ratio is necessarily above 1 or below 1. Dr. Wade's going to add.
Yeah, I just have one more comment on that. So for the smaller OPOs, the estimate of the standardized donation ratio will be less precise, so there's just more variability, random variability in that particular ratio, which means just by random chance there'd be further above 1 or further below 1 than the larger OPOs.
Which is the reason why that what we call a funnel plot, that we stratify that by size, allows you to see that as we move to the right with the larger OPOs, you'll have less variation in those estimates, and if we move to the left, you'll generally see a wider spread in those estimates.
Yeah, and that's very common in pretty much all of the plots that we present for OPOs and transplant programs. So,
Great.
Next question is, what will the SRTR's role be in addressing the recent executive order requiring OPO performance metrics to be developed in 90 days?
That's a great question. Just to set the stage, I'm sure you're all aware, President Trump issued an executive order approximately 2 weeks ago. Part of that order had a lot to do with kidney care in general, dialysis care, incentives for living donors, and part of that executive order was that there should be a newly developed Organ Procurement Organization performance monitoring metric within a period of 90 days, which would put us at about early October of 2019 to have a metric proposed. SRTR has been doing research into different ways to construct performance monitoring metrics to aid HRSA in this regard for a while now. We are continuing to do so, and we will be taking our marching orders from HRSA in terms of what, if anything, will be involved in addressing that executive order directly. So I don't have a lot to add at this point other than that we are in conversations with HRSA about how we can be helpful. Obviously, this is a research focus for the SRTR, and so I think we have good things to add in that regard, but we will take our orders from HRSA in terms of what they need for our support in that.
Okay, great. And the final question before we wrap things up today. I believe you stated the adjustments on the whole donor yield, eligible donors divided by eligible deaths, are age, gender, race, and cause of death. Where can we find how those impact the expected yield?
Great question. We have a number of tools on our website for the yield models and the other offer acceptance models and post-transplant outcomes models. You are pointing out one area where we currently do not have an application on the SRTR website to provide that model directly to you. However, if you simply email the SRTR if you want more information about that model, we have the model. We're happy to provide that to anybody who asks. So again, it's a simple adjustment given the limited number of data points we collect on eligible deaths. But if you want more information on what that model looks like or how the factors are factored into that adjustment, we're happy to provide that. Simply email us srtr@srtr.org, and we'd be happy to provide that. Great, that brings us to the top of the hour. This webinar has been recorded and will be made available as soon as we can convert it onto our webinar page on our website. And again, you can find all of the SRTR webinars located there. I will also highlight that Amy has led an effort to provide a number of other instructive webinars that are there on that site for how to use various areas of both our public website and our secure website. So if you have the time, those are great webinars to learn a bit more about where you can access information within the SRTR. So thank you all for your attendance today, and we will be having another webinar in about a month and a half on transplant program waiting list metrics. So stay tuned for that one as well. Thank you all for your participation, and have a great day.